Hello and welcome to the series Metabolic Acidosis and Chronic Kidney Disease, Evolving Management Strategies. Today's session is the second of 3 weekly modules and is entitled Diagnosis and Management of Metabolic Acidosis and CKD. My name is Dr. James Matera and I will be the moderator for today's program. I'm the Senior Vice President for Medical Affairs and Chief Medical Officer at Central State Medical Center in Freehold, New Jersey. And I'm pleased to be joined by Dr. Vandana Mathur, who is president of Mathur Consulting and on staff at the Clinic by the Bay in San Francisco, California. Here are our disclosures for today's program. We will be discussing off-label use of the following for treatment of metabolic acidosis, including sodium bicarbonate, potassium, and sodium citrate. Today's session is approved for 0.5 CME, CNE, CPE, and AAPA credits. And these are provided by the North American Center for Continuing Medical Education, LLC, and HMP Company. We are also supported today by an educational grant from Tracida Incorporated. The learning objective for our program today is we are going to evaluate the benefits and risks of the currently available treatment strategies we have for metabolic acidosis. So Dr. Mathur, thank you again for joining me for Module 2. We had some very good physiology in our first module, and now we're going to get a little bit more into the meat of what the clinician needs. So let's talk a little bit first, though, about metabolic acidosis and how we diagnose it in chronic kidney disease. So we usually will diagnose this in patients with CKD when the serum bicarbonate concentration, which is or serum total CO2 concentration, which is a surrogate assessment of the bicarbonate, is consistently below 22 milliequivalents per liter. When you have acid accumulation that you see in metabolic acidosis, when this happens in CKD, it begins way before the sodium bicarbonate even begins to decline. And you touched about that on that a little bit and how the body adapts to the acid loads and acid management. But as early as CKD stage 2, which would be termed a milder form of CKD, some of these processes are already in place, setting the groundwork for the development of a more substantial acidosis. Low serum TCO2 concentrations is also seen in respiratory alkalosis, and distinguishing this particular acid-base disorder from metabolic acidosis requires measurement of the systemic pH and the pCO2. So some of our chronic lung patients, we have to make that distinguishing factor. The anion gap is also very important here, and we alluded to the fact that it could be a high anion gap or a non-anion gap acidosis, but the higher the levels of the anion gap are, they're associated with an increased risk of all-cause mortality after we adjust that for variables including age, gender, race and ethnicity, and the estimated GFR. So anion gap does play an important role, and again, one of the banes of the medical student's existence. Okay, so KDIGO came up with some guidelines for us as far as metabolic acidosis is concerned, and these were published back in 2013. But chronic metabolic acidosis is associated with increasing protein in catabolism, uremic bone disease, muscle wasting, chronic inflammation, which we heard in Module 1 is an impactor and leads to fibrosis, impaired glucose homeostasis, impaired cardiac function, progression of CKD, and then all those together increased mortality. So anything we can do to reduce the mortality in this already compromised patient population is so important. So KDIGO actually said, we suggest that in people who have chronic kidney disease and a serum bicarbonate level consistently below 22 millimoles per liter, that treatment with oral bicarbonate supplementation be given to try to maintain a serum bicarbonate within the normal range. This is, of course, unless it's contraindicated. And a lot of times we see that with our patients who may have congestive heart failure, that may not be a very good therapy for them. And we showed a slide last module about the compliance with bicarbonate therapy being very low.
Absolutely, and and those patients whose blood pressure we're trying to get to target, where maybe the last thing you want to do is to add more sodium to the mix and just make your life harder.
Yes.
And I think there's also this interesting aspect where we talked about the SGLT2 inhibitors, but of course traditionally We use ACE inhibitors and ARBs to reduce cardiovascular and renal outcomes in these patients, and the effects of these medications are negated by a high sodium intake, based on analyses of classic ARB trials. Both the cardiovascular risk reduction and the renal risk reduction is negated, in patients who are consuming a lot of sodium. So I do think this is challenging, and I think the words of KDIGO are pretty spot on. That I think it's reasonable to consider unless you've got a patient where you feel there's a contraindication.
And that is such a great take-home point. We recognize that not adhering to a low sodium diet can really have an impact on some of the therapies we're giving, and it becomes so important. And yet we're stuck giving patients sometimes a medication that has sodium in it. So how can we approach treatment to metabolic acidosis knowing some of these things? Certainly we can increase base content in a patient's diet. We can try to neutralize the acid, which is most often what we do, by administering a base either in the form of a sodium or potassium salt, primarily sodium bicarbonate, but also potassium citrate, understanding the risks associated with that. We can also try to replace that renal acid excretory capacity that's lost by trying to remove acid from the GI tract. So don't get the acid in because you're not going to be able to excrete it, thus developing the acidosis. So those are the three key points that we'd like to focus on how we can treat this. So dietary strategies. I think this was a great study done also about 8 years ago or so, where we looked at the potential acid load or the potential renal acid load for different types of foods. Over to your left side in the purple is the more acid producing foods, which certainly one would want to avoid. And over to the right side, more base producing foods, which we'd want our patients to adhere to. But the discrepancy here is a lot of times with our chronic kidney disease patients, the things that would produce base also have other factors associated with them, such as phosphorus load, potassium load, different things that may not be very beneficial for our patients. We also know to the left side there, we see all of our proteins, meat, fish, things like that, which we want the patients to avoid. So striking that balance between what the patient with chronic kidney disease can handle to produce more base on a food aspect or food scale is very complicated sometimes. Most of these patients, they may have diabetes, they may have high blood pressure, all these factors that impact their diet in some way. So if we're restricting protein, we're restricting sodium, we're restricting everything, it becomes a much less palatable diet, and people tend to not want to take in that diet. The classic American diet, being an acid, ash-based diet, does not bode very well for these type of things. So we have to be very cognizant of that in our population. Dr. Mather, do you have any experience with your patients and dietary strategies?
I spend a lot of time doing dietary counseling because I think it's one of the simple ways you can modify a number of risk factors. But I completely agree that it is very challenging. Once you have diabetes in the mix, once you have advanced CKD in the mix, the number of things that we need the patients to restrict: their potassium, their phosphate, their acid load, their sodium. They're not left with too many foods that they can actually eat. And to try to stick with that kind of diet, I think is a big ask, and understandably difficult for patients to adhere to.
It is. Okay, so with that in mind, and knowing that we have challenges on the dietary side, although certainly something to strive for, we do have some pharmacological options, and they basically run in the form of administering alkali, although we do have some newer agents, which we'll talk about shortly. So the mainstay of therapy is sodium bicarbonate, either in the form of tablets or powder. They do provide certain milliequivalents of bicarbonate. They are inexpensive. They neutralize acid. With the sodium preparations, they're not combined to potassium, so we don't have that extra potassium salt that oftentimes our patients have to adhere to. We also know a lot of them are on medications like ACEs and ARBs, which tend to drive up the potassium. Some of them may also be on potassium-sparing diuretics in congestive heart failure. So potassium is something we really have to monitor. But we all know that these have GI issues due to the generation of CO2, and that's probably one of the biggest components for that large discontinuation factor we see with our patients. Sodium bicarbonate powder can be used on food. Some of my patients tolerate that, but most of the time they'd rather take the pills. We do have sodium citrate available to us as well, which provides about 1 milliequivalent of bicarbonate per milliliter. Does reduce the GI symptoms a little bit, but if anybody who has any type of liver decompensation or liver issues, it can impair the conversion of the citrate and thus be a little bit less effective as a buffer. Also, no potassium in here. Our next two, potassium citrate, whether it come in the pill form or a citric acid packet, they do have the potassium in there, and they also use citrate as the agent that needs to be converted in order to buffer. There is some aluminum absorption that occurs here because it's bound to potassium instead of sodium. That dissociation can lead to some hyperkalemia, and we have to be careful on that. And again, the conversion can be impaired in liver disease. So those are the basic tenets, but we do have some newer agents, in particular Viviramir. We don't know right now how many milliequivalents of bicarbonate in this drug, but this is a little bit different because this binds the hydrochloric acid in the GI lumen so that it doesn't get absorbed into the system, where the kidney in these stages of chronic kidney disease can't excrete it. So that's a very new way of looking at this. Rather than a buffer, you're actually going to decrease or allow the kidney to handle by eliminating some of the acid load in the GI tract. I think that's a very good method of doing this in the future.
Yeah, and I would add that there is no bicarbonate in Viviramir. It's not, the whole strategy with this drug is not to neutralize, but rather just to bind up the acid and get rid of it. And because it's not a counter ion, it doesn't leave any sodium behind or any other anion, so there's not any potassium or sodium to be concerned with, and there's also no bicarbonate. It's simply working by taking the acid out of the GI tract. So it's really just a completely different approach than we have used thus far.
Yeah, and we've been dealing with binders mainly in our potassium level for many years, starting with sodium polystyrene and on to the newer agents. So we're always trying to bind the bad things for our chronic kidney disease patients. Right. So this may be another way to trick that hydrochloric acid from being absorbed into the body.
Yeah.
I'm going to turn over the rest of this module to Dr. Mather, and we'll talk a little bit more on metabolic acidosis and comment along the way. So Dr. Mather.
Okay, yes, and even since the KDIGO guidelines were published back in 2013, there's been a lot of work in this area of metabolic acidosis and CKD progression. And what we are continuing to learn, really reinforcing what KDIGO had summarized, is that treatment of metabolic acidosis retards progression of chronic kidney disease. And no matter what kinds of different endpoints have been used in these various trials, it has been shown to improve patient-centered outcomes and to the adverse effects of sodium bicarbonate on electrolyte changes and other adverse effects have also been looked at in these newer trials. And there was a recent meta-analysis that from 2019 that looked at clinical trials that were conducted using various treatment strategies for metabolic acidosis, including dietary strategies, oral alkali strategies in patients with CKD 3 and 4 and 5. And these trials were typically single center, open label, and the controls varied from either no treatment or usual care, and in a couple of them, an actual placebo control. And what they learned overall is that there was a significant increase in serum bicarbonate with treatment and the slowing of progression to end-stage renal disease and progression of CKD.
Yeah, I think that's a key component, something that we have to have in our armamentarium when we're treating these patients. There's so much that has progressed on how we can try to slow the progression. I think we have to be very cognizant and aware of the things we have available.
So this was a meta-analysis of 14 clinical trials with approximately 1,400 patients in aggregate. And they looked at the treatment of metabolic acidosis with oral alkali supplementation or reduction of dietary acid, and found that on the balance across these studies that were meta-analyzed, that treatment of metabolic acidosis slowed down the decline of eGFR, with the average decline difference relative to the control arm being 3.28 ml per minute per year, which is certainly a big effect, and a reduction in urine albumin excretion with lesser certainty in these trials, and a risk reduction of progressing to end-stage kidney disease with a relative risk reduction of 0.32. Also of some lesser certainty because not all of the trials, I think, evaluated the ESKD outcome. On the other hand, oral alkali use was associated with worsening hypertension or requirements for increased antihypertensive therapy. Trials that have looked at treatment of metabolic acidosis have focused on kidney progression type outcomes. There have also been a couple of studies done looking at the effects on muscle and bone. And I think our best data on treatment of metabolic acidosis really comes from kids with CKD who do not grow well until and unless you correct their metabolic acidosis. So it tells us how important this is for skeletal maturation, and as well from patients who have renal tubular acidosis. And in those patients, treating metabolic acidosis will increase their bone mineral density, as one would expect based on the physiology of bone demineralization that occurs with acidosis.
And if we take a look at the whole spectrum of our chronic kidney disease patients, there's so many things that affect bone mineral density in them. It just leads to, again, another risk factor for them as time goes on. And we have gotten better at treating that, but just another component of what can be involved in that. We've done a lot of work with secondary hyperparathyroidism and those type of things, but all these things are just so intricately woven together that we have to just remain at the forefront of these type of diseases, especially as the patients start to age.
Yeah, and the fracture rate continues to be very high, in this population, despite what we're doing currently in these patients. Because of their age, they don't do well, once they've had a hip fracture and become immobilized for a period of time. So it's absolutely something that we want to try to avoid. So, so how much should we treat metabolic acidosis? What should be our target if we are planning to treat? And I think we have a few data points that help us understand this. One of them comes from a series of studies that have looked at bicarbonate as a risk. And if we look at the graph here on the right, what it's showing us is that for every 1 milliequivalent decline in total CO2 or bicarbonate, there's an incremental linear risk of probability of a 40% decline in eGFR in patients with CKD. And this was done in patients with CKD and GFRs less than 60. And across the spectrum of studies, every 1 milliequivalent increase in serum bicarbonate was associated with a 3 to 8% reduction in renal replacement therapy and or CKD progression. So again, as we've seen, in the earlier trials, big effects. And this would suggest that really every 1 milliequivalent that you can raise that serum bicarbonate is going to be meaningful in terms of the risk reduction that you can gain. So, so what about on the other side, if you were to overcorrect metabolic acidosis? And one of the things that we have seen from data, particularly from the CRIC trial, where they looked at the relationship between serum bicarbonate levels and risk of CKD progression as well as cardiovascular risk, what they found is that the sweet spot really for the optimal bicarbonate concentration was around 24, 26, but really the significant downside happened with alkalotic range bicarbonate levels, and at these levels there were significant increases of increased risk of heart failure. Now again, from an observational study, we don't know, why those patients are in the alkalotic range necessarily. Do they have just really bad heart failure? So they're on a lot of diuretics and they're getting alkalotic from being volume contracted. But nevertheless, I think, we should consider, the balance between, treating and correcting metabolic acidosis and maybe overdoing it and getting patients to be alkalotic. So somewhere in there is probably the optimal range. But honestly, I think most of these people with metabolic acidosis, just getting them into the normal range is challenging. And I think it would be very difficult to overcorrect in a lot of these patients just because they're starting out with quite low bicarbonate levels.
Yeah, that's very important. The balancing act that we have to go through can oftentimes be very difficult. And if you look to the right side, those red things, well, our patients are already at risk of those. We know they're in positive calcium balance, and just over treating this particular entity could lead to worsening calcification, increased risk of death, cardiovascular outcomes. So everywhere we look in renal, there's so many balancing acts we have to take into account. We know on the left side what we can do good, and we know on the right side what our outcomes may be if we overshoot. So very difficult to manage these things.
Yeah, but on the other hand, fortunately, every time we get a CAM panel, we can see the bicarb, so we can always titrate our treatment to, to optimize their serum bicarbonate concentration. So at least we're not working in the dark. Okay, so I think what we have learned from the available data is that correction of metabolic acidosis may help to slow progression of chronic kidney disease, as well as improve other comorbidities related to muscle and bone loss. And despite this, this knowledge has been present since 2012 when KDIGO guidelines were last updated, and the data that has been published since then, only a small percentage of patients are actually being treated today with alkali treatment. And I think that, it's raising, it's highlighting the balancing act that nephrologists need to have, when deciding on, administering sodium to patients with chronic kidney disease. The other part of this equation is, of course, the patient and their willingness to take some of the treatments that we offer them. And we know that the rates of discontinuation of oral alkali is high, and the adverse event rates are also high, particularly with respect to GI issues.
Great points. I think we'll see in our final module some things that we may have in the future, some novel therapies that may help us deal with some of these consequences that we see, and yet achieve the outcomes that we want for our patients. So again, I think a very good session here, Dr. Mather. So we'd like to thank you for joining us for the program today. If you have any questions, please submit them in the Submit a Question tab located in the right-hand navigation bar. One of our expert faculty will respond to your query. To receive your continuing education credits for today's program, please complete the evaluation located also on the right-hand navigation bar, and then you'll be able to download and print your certificate. Please join us next week when we launch Module 3 of this series, Novel Approaches for the Management of Metabolic Acidosis. Once again, from Dr. Mather and myself, thank you for participating in this program.